Thank you for joining this JRCALC podcast. I'm with Dr. Lucy Bates, and we're going to be talking about the new JRCALC Emergency Tracheostomy and Laryngectomy Guidelines. Thanks, Lucy. I'll just briefly introduce myself and then I'll let you introduce yourself. So I'm Emily Le-Gallienne. I'm a sector clinical lead from the East of England Ambulance Service, and I've done a lot of work within my service around emergency tracheostomy management, which led me to do a little bit of work outside of the trust as well and meet some lovely knowledgeable people like Lucy. Lucy, would you mind introducing yourself?
I'm Lucy Bates. I'm an intensive care consultant at Bolton Hospital in the northwest of England. And I'm one of the co-founders of the National Tracheostomy Safety Project, which started in about 2008 when I was a doctor in training. And I became a little worried that I didn't really know what to do with a patient with a tracheostomy if there would be an emergency. And it was me as the first responder in a hospital setting. And then myself and 3 other doctors got together and founded the National Tracheostomy Safety Project. And here we are all these years later, trying to keep all patients that we call neck breathers safe.
Amazing. Thanks, Lucy. And the National Tracheostomy Safety Project work is something that we've really tried to bring into this guideline update, haven't we?
Yeah, we're just trying to keep everything streamlined and simple, and trying to adapt a little bit the work we've done for in-hospital tracheostomy and laryngectomy patients for those of you on the front line who have to go out into the community and deal with these situations.
Yeah, and I'm really pleased that you mentioned back when you were at the early stage of your career feeling quite apprehensive to have to manage one of these patients, because that's certainly something that I hear from my colleagues in the ambulance service. This is why this is such an important guideline for us, because it's one that we're probably going to need to refer to when we're on scene with our patient, because we're not going to be that familiar with the care of these patients.
Yeah, and that's sort of where I came from. It was very obvious in intensive care that somebody had something coming out of the front of their neck, but I was never completely sure why it was there and what it meant for me and them if I had to deal with it in a hurry. And it's fairly rare, but when it's happening, you have to act quickly and you have to have some basic idea of what to do.
So, should we talk a little bit around the work that we've been doing as part of the working group? So, myself, Lucy, Dr. Catherine Doherty as well, and Lewis and Kevin from the London Ambulance Service have been part of this working group. So, we've got a new section on management of children with tracheostomies. We've got some new algorithms, talking a little bit around what we've touched on, that it's just airway management and we need to reassure one another that doing something is better than doing nothing. And keeping it simple, I think, is really key.
100%. And I suppose the biggest sort of myth and thing that people say to me is, if we take out a tracheostomy tube, the airway is going to collapse. And that's said, whether that's resident doctors or when we've been developing these guidelines, that's said out loud so frequently, and that isn't the case. And that needs to be something that I can hopefully reassure you all from today, that if you follow the guidance that we're putting out and the algorithms, things will improve.
So, Lucy, if we go back to basics, what is a tracheostomy?
So a tracheostomy is essentially a hole or an opening made in the front of somebody's trachea, in their windpipe. There's lots of different indications to do a tracheostomy, but the long and the short of it is, once the tracheostomy's been done and we're more than 7 days down the line, you can treat them all the same in an emergency.
Great. Okay. And what might some of the indications be? What might some of the most common ones that we might see in the community?
So in the community, people who end up with a more permanent tracheostomy are 2 groups of patients, really. They've either got some form of ongoing upper airway problem that they can't have resolved, either a surgical reason or a neurological problem with their swallowing, or there might be somebody that's ended up on a long-term ventilator who's got a long-term neurological problem. They're the kind of adults that would be living with a tracheostomy in the community.
Okay. And we talk in this guideline around laryngectomy as
Yeah.
well. So can you just briefly explain what the difference is between a laryngectomy and a tracheostomy?
So a laryngectomy is when a surgeon has removed the patient's voice box. So there is no communication between the upper airway, the mouth and the nose and the back of the throat, and the trachea. That bit of the larynx has been removed, usually for cancer. And then the surgeon brings out the end of the trachea, so the end of the windpipe, out onto the skin surface. So it's the most straightforward airway you are ever going to come across because it's sat right there on the front of the patient's neck looking at you. And the nose and the mouth are not attached anymore to the airway. And I think it's that. If we can get that message across, that if somebody's had a laryngectomy, what you're looking at when you're looking at the neck is the end of their trachea. So it's the most straightforward airway you could ever come across because you've not got to navigate all the soft tissues of
Yeah.
the tongue and the back of the mouth and
Yeah. And I suppose something that we come across quite a lot in the ambulance service is lack of information in an
yeah.
emergency environment. So what might we be able to tell the difference between whether that person that we're treating has a tracheostomy or a laryngectomy?
So typically with a laryngectomy patient, they've also had a lot of surgery on the sort of the tissues of the neck. And you tend to see the neck looks very slim and it looks like it's lost its muscle anatomy and they look almost scrawny is a word I'd use to describe. Whereas a tracheostomy patient has usually got a fairly normal looking neck. They shouldn't have scars. It doesn't look like they've had other structures removed. And typically, a tracheostomy patient will tend to have a tracheostomy tube in the stoma, whereas a laryngectomy patient may have all different types of coverings over the
Uh,
stoma, but not necessarily a tube. So if you see somebody wearing the white bib, which is a Buchanan bib, that's a humidification bib, and that would be a laryngectomy patient. If you see somebody that's got a very tiny little tube in their airway, that's more likely to be a laryngectomy patient. It's a humidification device. And if you see somebody with nothing, just a stoma, that's much more likely to be a laryngectomy. Whereas if you see somebody with what looks like a more traditional tracheostomy tube and a neck that's looking relatively normal, that's more likely to be a tracheostomy.
Okay, great. That's really helpful. And within this guideline, we've done a glossary of terms, haven't we? And we've got some
Yeah.
images in there because there's certainly a lot of equipment that a clinician might find on scene that they aren't familiar with. So there's a little bit in there around care plans. Can you talk to me briefly about what would
Yeah.
happen to these patients when they're discharged from hospital?
So, in an ideal world, all of the patients that left any hospital in our country would go home with a care plan, a sign that they've got immediately visible around their kit to say what they've got and what they've had done. But in the adult population, we're not there yet. So it's a bit mismatched around the country. Whereas in the children's population, they've got a very good setup where they all go home with a bedhead sign and information. So we're a bit
Mm,
behind on the adult population, but essentially, when somebody's discharged from hospital with a trachea or a laryngectomy, they should have some spare kit at home. They may have some suction equipment. They don't all have that. And they should either be trained themselves to manage their stoma or they should have their carer, family member able to help manage their stoma. They should have a spare inner tube for the tracheostomy tube. They don't all have spare tubes at seam, but again, some of them might have. So you're going to, unfortunately, you're going to see a bit of a mix depending on which area of the UK they've been discharged from. And we're
okay.
trying to streamline it, but we're nowhere near there yet.
Yeah. And we see that across lots of other areas of practice as well,
Yeah.
don't we? So I think that's something as clinicians working in an ambulance service, that's something that we're quite used to having to manage that variation between different geographical areas.
Yeah.
So what might be the most common causes that we might get called as an ambulance service to a neck breathing patient?
So the most common problem and the most straightforward to resolve is um, an obstruction within the piece of plastic sat in the front of their neck. and it's usually sputum, and it's usually sputum that's got a bit dry and a bit crusted. And with a tracheostomy patient, they have the outer tracheostomy tube, and then they have an inner cannula, so a tube within a tube. And the inner cannula you can take out, and 9 times out of 10, if you take out the inner cannula and the sputum crusted and plugged off, you will relieve the problem. And it's that simple. It's literally a tube with an inner tube, and the inner tube has got blocked. If you take the inner tube out, the patient should then be able to breathe through the outer tube that's still present in the stoma. And they may have a fresh inner tube. They should have a fresh inner tube at home that you can put back in. You don't necessarily need to put anything back in. You'll have cleared the obstruction by just taking out the inner tube. The other sort of difficult problem with patients look like they've got a blocked tube is the tracheostomy tube itself may have moved within the soft tissues, and you may be looking at a piece of plastic that looks like it's where it should be, but it's actually become displaced, and it may be partially out. So you may be looking, thinking, oh, it looks okay, the inner cannula looks clean, what's going on? And that's a displaced tube, not all the way out, but part the
Mm,
way out or migrated into the soft tissues in a false passage. So
okay.
blocked cannulas, displaced tubes, and tubes that have come all the way out are the things that you'll see.
Okay, and they're all of the things that we are addressing as part of our emergency algorithms, aren't they? Which
Yeah.
we'll talk about a little bit later. Something that I did want to talk around was around whether our patients have patent upper airways or not, and what that might mean for our management of them. Is there a way that we can identify whether that patient might have a patent upper airway?
So if we're just talking about tracheostomy patients, the majority of those patients will have normal anatomy above their stoma, above their tracheostomy. So if you have to manage their airway, you can go back to basics and manage their nose, mouth, back of throat like you would anybody else. Um, there will be a very small number of patients out in the community that might have a head and neck cancer that hasn't been resected and may have a more challenging upper airway. But I don't want people to fixate on that because they're small numbers of patients.
Mm,
If you've had a laryngectomy, your upper airway anatomy will be normal, but the bit that connects the upper airway to the trachea has gone. So you can do whatever you want to the upper airway, but you won't get any oxygen into the lungs because the
yeah,
only bit that the upper airway connects with is the stomach.
great. And I know that obviously it's something that people might find a bit nerve-wracking if they're not sure whether that patient has a patent upper airway. So, if we're not sure, what should we do in that
Yeah,
instance?
so if you don't know, the safest thing is to assume that their upper airway is connected to their lower airway so that they're a tracheostomy and apply oxygen to both. So if you're not sure, put oxygen on the face and oxygen over the stoma as a temporary measure so that the patient can get oxygen through whichever means. If they're a laryngectomy patient, you're not going to do any harm. You'll put a bit of oxygen into the stomach. But if they're a tracheostomy patient and you don't put oxygen through their upper airway and their trachea is blocked, you're not getting any oxygen into them.
That makes perfect sense. And I suppose just thinking of what my ambulance service would carry into a call, we wouldn't necessarily have a certain number of masks available. We might not be able to facilitate that straight away. And I know that not all ambulance services carry specific tracheostomy masks either. So something that we teach is just to use the smallest oxygen mask that you've got
Yeah,
available that will fit over
over the
that
stoma.
stoma.
Yeah.
Yeah, great. Okay. And then the other thing I just wanted to talk to you about was suctioning, because I know that that's something that definitely used to fill me with fear, particularly because it's something that we don't really have any training in tracheal suctioning at all. So, can you talk to me a little bit around the importance of suctioning and how we would do it right?
So the idea behind suctioning somebody's tracheostomy is twofold. The first thing is to try and help as a guide to see whether that tracheostomy tube feels like it's in the right place. And a tracheostomy tube in an adult is about 10 centimeters long from the start of the plastic at the neck to the tip in the airway. So if you're passing a soft suction catheter and it passes with ease beyond 10 centimetres and the patient coughs, that's a really good indication that you're in the airway because you're stimulating a cough. At the same time, if you've got it attached to a suction unit and there's an increased sputum load, maybe they've got a chest infection, or then you can apply some suction on the way out, and you'll have sort of killed two birds with one stone. You'll have proved that the tracheostomy is in the right place, and you'll if there's sputum there, you'll be able to suck the sputum out as you come back out. When you haven't done it, it may feel daunting, but once you've done it, you're very unlikely to cause any harm with a soft suction catheter and a portable suction unit. And you may well relieve a sputum plug that's further down the airway that's causing them distress.
So shall we go through the algorithm
Yeah.
and just talk about the steps that we would take? So right at the top, we've got safety, stimulate and oxygen before we do anything else. Why are those steps so important?
So you need to make sure your area is safe in any emergency. You need to keep yourself safe before you treat the patient, because otherwise no good will happen. And then we're going to check their airway, which essentially tracheostomy management is all about an airway assessment and checking the airway is patent and checking that the patient can get whatever oxygen you're able to deliver into their lungs. And oxygen wherever you can put it, however much oxygen you're carrying, and with whatever oxygen mass you've got, put it on all orifices is my motto.
Great. Yeah. And I think this is something that is really worth considering in our setting, because typically we would only carry one cylinder of oxygen into a patient's home or into wherever we're going. I know certainly a lot of the tracheostomy patients that I've been to when I've been working on the road have been within like neurological rehab centres, so they might have piped oxygen on the wall, but typically we only carry one cylinder and you might actually need a second one. So would you say it's a good idea, if you know that you're going to a neck breathing patient, to take an extra cylinder in with you?
If you've got that as an option, that would definitely make things easier for you, rather than having to swap oxygen between the stoma and the face as you're trying to work out what's going on.
Yeah, and it definitely helps with that human factors side of things if you're prepared to take that equipment in.
Yeah.
The other thing that we've got at the top of the algorithm is around capnography and end-tidal CO2. Can you talk to me a little bit about that?
Yeah, so CO2 is the gas that you breathe out. So if you're ventilating, breathing, and you can see a CO2 trace, or you've got a colour change capnograph, that is reassuring you that your oxygenation and ventilation in that patient is effective. So it's either their spontaneous ventilation or your assisted ventilation if they're not breathing. So if you have the ability to use capnography, then it is another aid to working out what is wrong with the patient, whether the patient's airway is patent, whether they're breathing effectively. So do you carry the colour change capnographs with you, or do you have the side stream ones that we have in hospital that attach into the circuits?
So within my service, we have a side stream kind of we have like inline capnography. I know that most other services are the same. I'm not sure if any are carrying colour changing capnographs, but we certainly have all got access to monitoring end-tidal CO2, and it's worth mentioning that we have that 15mm connector on the end of the tracheostomy tube, which means we can attach all of our equipment directly to it, doesn't it?
Absolutely. And it's another aid for your airway assessment to see whether that tracheostomy is patent, which is what all this is about. So if you've got somebody who's breathing spontaneously and you put your capnograph into your circuit and you see a trace, then you can almost take a sigh of relief before you've even gone beyond that step, that maybe their problem isn't related to a blocked tracheostomy tube, it's something else making them unwell. So it's all about like building the clues as to what it is that's causing that patient to be unwell. And just because they've got a tracheostomy or a laryngectomy, it doesn't mean it's that, but that's the first thing you have to assess.
Yeah, absolutely. So as we move through our algorithm, the first step that we get to where we have a question is our patient breathing?
Yeah.
And if they are, we're applying our high flow oxygen, as you say, to both the face and to the tracheostomy stoma. And if they're not breathing, we're going to consider requesting critical care. And I suppose I would probably say that we should consider requesting critical or enhanced care quite early with these patients
Yeah.
anyway. From your experience in hospital, in like a critical care setting, what would be the advantages of having an extended scope of practice, a more advanced clinician come to that patient?
I think we just see more of these patients, so we're just very slightly less anxious about it than people who
Mm.
don't see it very often. So it's about team working and using clinicians that you've got access to that may have seen a tracheostomy more recently or at all, because I assume some of the crews that go out to people's homes will be coming across this for the first time. So it's having somebody else there as reassurance. But my message is you can deal with this situation as a paramedic in the field if you follow this algorithm without any other support. 100%.
Great. And that's so good to hear. It's so reassuring, I think, just to know that someone with your experience thinks that actually let's just take it back to basics
Yeah.
and manage that airway. And it might not be the airway that we're used to managing traditionally, but the same principles apply, don't
Same
they?
principles, 100%. Yeah.
Yeah. Something that is referred to within the algorithm that we haven't spoken about yet is around speaking valves
Yeah.
and other kind of things that might sit on the outside of a tracheostomy tube. So what might we see? What do they look like, and what do we need to do with them?
So the cap that was referred to, there won't be a cap. A cap is only really used in hospital when we're assessing whether somebody can manage without their tracheostomy. Cap is essentially something we block a tracheostomy with to see whether the patient can breathe around it and therefore will cope without it. So put the cap to one side, you won't see it.
Okay.
Um, a speaking valve you might see. So a speaking valve is used exactly as it says to help somebody with a tracheostomy speak. And they look like a little bit of plastic that's got a sort of a grid on it. It's a one-way valve that allows airflow in one direction. And if you're going to need to attach anything to the tube, so capnography or your 15 millimeter connection for an ambu bag or a circuit, you need that speaking valve out of the way. So they're very easy to just take off. So anything that you see on the end of the tracheostomy tube that looks like that it's an additional thing, just remove it at this point. It makes things more straightforward.
Okay, great. That's really helpful. And as we mentioned before about the glossary and the images that we've got within the guideline, I think they're going to really help clinicians to
Yeah.
see what this equipment is, because there is quite a lot of equipment that they might not be familiar with at all. We've spoken about suctioning, and that's been really helpful, and that's the next step in our algorithm. And if we aren't able to pass the suction catheter, then we need to start considering a cuff around the tube and whether there is one present and if we need to deflate it. So how might we see if there was a cuff on that tube?
So most patients out in the community, if they're not on a ventilator, won't have a cuff. If they have a cuff, you'll see like a pilot balloon, like you see on an ET tube,
Yep.
dangling external to the tracheostomy tube. And that indicates there's a cuff. Doesn't necessarily mean the cuff is inflated. It's the same as an ET tube, the pilot balloon. If it's fat, the cuff's inflated. If it's flat,
Yeah.
the cuff's deflated. So again, you may come across different tubes and different cuff scenarios, but a pilot balloon is what will give that away.
And why would we be deflating a cuff if it was present at this point? What does that do?
So if you have a tracheostomy tube in the airway and you've taken the inner cannula out and it's not blocked and you've put it back, you've passed your suction catheter and you're not sure, you're not getting it past 10 centimeters, it's hitting a bit of a barrier, there's no cough, the patient's not getting better. The next thing is, well, where is this piece of plastic? Is it sat in the airway? Is it up against the wall of the airway? Is it changed position? Or is it sat in soft tissues and it's not in the airway at all and it's useless? So at this point, you've assessed that this piece of plastic in their airway is probably not helping them. But if the cuff is up they're still trying to breathe through a blocked or a displaced tube and the cuff is up, they can't breathe. You're suffocating
Sure.
them essentially. So at this point, if you let a cuff down, you create a space around the tracheostomy tube to allow them to breathe through their upper airway. So we're
Great.
buying a bit of time, allowing the patient to breathe around a tracheostomy tube that may be blocked at the tip of the tube, not in the inner cannula, or it may have moved, and so they're not able to breathe through it.
So hopefully that works. And if it
Yeah.
doesn't, then we need to just remove the whole tube.
Yeah, if it doesn't, that tube is a foreign body in that airway. And my analogy for adult patients is if you get called to a nursing home for a resident choking on their breakfast sausage, you'd be trying to get that sausage out the airway.
Yeah.
We have now got a piece of plastic that is a foreign object somewhere in an airway, around an airway, not in an airway. You've proved by the steps you've done so far it is not doing what it was meant to do. You're going to take the foreign body out of the equation. The airway is not going to collapse. The trachea is not held open by that tracheostomy tube. The airway will stay exactly as it needs to stay. And you'll have a situation where you've got a hole in the front of the neck and you've got an airway that they should be able to breathe through because you've removed the foreign object. So again, if you've
Great.
got two oxygen supplies and you put one over the stoma with now the tube's gone and one over the face, whichever their path of least resistance is, they will breathe oxygen through this bit of their airway or this bit, or a combination of both usually. So
Great.
it's sort of empowering people that you've assessed this. It's now not useful. It's a foreign body. No airway's going to collapse. Nothing disastrous is going to happen. You're going to relieve the foreign object from the airway and you're going to allow them to breathe.
So if we've done all of those steps and it hasn't improved, then at that point the patient might have deteriorated. And if they have
Yeah.
deteriorated to the point that they're no longer breathing, we've got our 2 emergency oxygenation boxes at the bottom of our algorithm. So our primary one talks around using the nose and the mouth and
Yes.
standard kind of oral airway maneuvers.
Yeah.
And it mentions covering the stoma.
Yeah.
How would you advise that we do that?
Just with your gloved hand.
Great.
So your crew member that's with you or the carer that's there, just ask them to gently put a hand over the hole like this and use
Yeah.
their upper airway. And the reason that we advise that is because everybody in a hospital or primary responder situation has managed somebody's airway, but very few people have managed a stoma. So we're trying to get people to go to familiar things and keep things familiar and take this out the equation. But if you don't cover it, if you
Mm.
have to do bag valve mask ventilation from the top, all that will happen is you'll get a big
Yeah.
leak through the hole in the front of the neck. So you just need to occlude it with your hand,
Okay.
this bit of your hand. There.
Lovely. So just with the palm of your hand, and
Yeah,
that's super duper easy to do.
yeah.
Um, and it's also got on there around using the tracheostomy stoma as a site that you could ventilate as well. How might we do that?
So there's two main ways. You can either use a very small face mask. So we use a pediatric size face mask, the little round ones for neonates, because they
Yeah.
sit really nicely over the front of the neck. Or you can actually use a laryngeal mask, and you can actually use where the seal of the laryngeal mask and the hole is, you can
Yeah.
hold it over the front of the airway and it creates quite a nice seal. Then you can connect it to your ambu bag.
So that seems really simple, but unfortunately, if that doesn't work, then we need to go to our other box, which is where we're really hoping that we're going to have some extra support here, because this is where we're starting to talk about oral intubation, and
Yeah.
in a lot of UK ambulance services, that is something that is out of the norm of paramedic practice now. So it might be that we need some additional support for that. If someone is able to intubate as part of their scope of practice, are we anticipating that this is going to be a difficult intubation?
Again, the majority not, because their upper airway will be normal and their tracheostomy will be there because of neurological reasons. The odd patient that might be tricky is if it's a head and neck cancer patient.
Yeah.
But assume that you can access the upper airway always. Don't just think, oh, I can't do it because of this But use an uncut tube, because if you use a tube that's been cut, it'll sit just at the level of the stoma and you'll ventilate air straight out through the hole. So an uncut tube, but all the normal standard approach to intubation.
And if we go down just to the very last box, it's around intubation of the stoma,
Yeah.
which I know we've got some really lovely images within our guideline just to explain to people what we might mean by that. Can you just briefly talk us through what we would be doing?
Yeah. So again, this is sort of last resort territory, and you're very unlikely to be at this point. You are
Yeah.
9 times out of 10, you will solve the problem by removing the inner cannula and the bit of sputum, or by realizing that it's in the wrong place and taking the tube out. If you get into this crisis situation where the patient isn't breathing and you haven't managed to help them breathe by any other means, you've got to try and access the stoma. And you've got two options. You either use a small ET tube, a size 6. Um, you can either just try and gently pass that on its own through the hole, or you can use the suction catheter that you've been trying to suction earlier in the algorithm, but cut the end that attaches to your suction unit off and literally use it as a guide and gently insert the suction catheter into the stoma. It's not going to do any harm because it's soft. Whereas if a bougie was suggested, that's quite
Mm,
hard and you could poke and make a false passage. Then if you
okay.
can gently pass the suction catheter into the stoma and it doesn't feel like it's obstructing or causing any problems, you can then slide either a spare tracheostomy tube that the patient may have or a size 6 CT tube in over the top of the suction catheter. So the
Right.
idea of the suction catheter is to use it as a bit of a flexible bougie.
Yeah. And so we're just going down to that first black line on our ET tube, right? When we
Yeah.
insert it.
Well, if you think about the anatomy of the trachea, you've not got a lot of distance between the
Mm,
second and third tracheal ring where the tracheostomy will have been sited and the carina. And if you go too far, even if you go as far as the black line, you'll have an ET tube in the right main bronchus. So you might need
yeah.
to pull it back a little bit. So if you pass an ET tube through a stoma and it's successful, you've got the capnograph on and you're bagging the patient and you're seeing the chest move and the capnography, but you notice the right hand side is going up and down and the left isn't. You've just been a bit overzealous with your ET tube because the distance is different from the distance
Yeah.
if you're orally intubating. But
Yeah, absolutely.
even if you end up ventilating the patient on one lung's better than no lungs.
That
So
is true. That is
yeah,
true. But so the key is just to be really gentle
yeah,
and use kind of all of the people that we've got available to us. So call for help,
yeah.
certainly. And if you were going to use a small tracheostomy tube, if that was something that your ambulance service supported you to do, um, would it need to be a cuffed tube if you were
And it
ventilating that
doesn't matter.
patient?
I mean,
Any?
if you have an uncuffed tube and you're using bag valve mask ventilation, you'll just get some leak.
Okay.
It doesn't matter. You'll still get some oxygenation and ventilation. Ideally, it's like if you pass an ET tube and you bag
Yeah.
them without putting the cuff up, you'll still get some chest movement, but you will get some leak. I think if you're at this point in the algorithm out in someone's home and you've got limited equipment, you use the best that you can do at the time to crisis
Yeah.
manage until you can get somewhere where there's more equipment and experience.
Great. And that's really key, isn't it? That we just want to manage these patients as safely as we can and
Yeah.
then get them to the experts in hospital, and we'll bring them all to you, Lucy. Um, so we won't talk through the entire laryngectomy
No.
algorithm because it's largely the same, isn't
Yeah.
it? It
It
just
is.
removes the option to use the upper airway
Yeah.
because we know that that's not going to
Not
help us very
connected.
much.
I suppose the one issue that I've seen with laryngectomy patients is they've had a cancer usually, and they do get recurrence. And we do
Mm,
occasionally see, sadly, a patient in distress because they've got a tumor recurrence around the
mhm.
stoma, and there is not a lot you can do. And this
Okay.
shouldn't become a battle to try and yeah. So there may be the odd patient that presents to some first responders who've got an obvious lesion at the stoma, and you might not be able to help that patient. But that is a
Okay.
sad situation that you can't do anything about. But take that small number of patients to one side and follow the algorithm and just use the stoma anymore.
Yeah, and I'm really glad you mentioned that actually, Lucy, because things like end of life care and looking after patients in their last few hours of their life is something that we have become a lot better at in the
Yeah.
ambulance service. And I suppose some of these patients that we are going to that are living with a tracheostomy or a laryngectomy might fall under that bracket.
Yes.
So
Yeah.
we don't want to be too distracted by the fact that they're a neck breather, because we still want to give them a dignified
Yeah.
ending to their life.
Absolutely. Yeah.
Yeah, great. This has been so useful, and I've learnt so much as always. So thank you so much. Just before we go, have you got any top tips, anything that we've not mentioned already that you think would be really helpful for us as paramedics?
Stay calm. It's more simple than you think. Follow the algorithm, and 9 out of 10 situations will resolve if you do the bits at the top of the algorithm and take the inner cannula out.
Great. Thank you so much, Lucy. It's been great to chat to you.